Okay, so I will record this on and we'll. All right. So welcome. Today is I'm going to talk on pneumonia and suppurative lung disease. So it will be. I try to finish just before about 9, because I also have some meeting has to attend, and you guys also have another lecture. So this is lecture outline. So number 1 is the learning objective. This one I won't go into detail. You can get it from the books, guidebooks that have been given to you. And then we go. I'm just going to talk a bit briefly regarding anatomy and some physiology, just to make sure that you understand regarding the to help you to understand regarding today's topic. And then pneumonia, I'll go into pneumonia, which is can be divided into two: bronchopneumonia and cerebral pneumonia. And next is lung abscess, and the last one is empyema with an additional few subtopic, which is the COVID-19. That one is a special issue. Um, I'm just adding this here. All right. So this, as you can see, as the new objective you can find in the guidebook. So for the anatomy, I think you already understand that the respiratory system consists of few main structure, which is number one, the up here, the trachea, and so oropharynx, nasopharynx, oropharynx, and then it goes into larynx and so trachea. Right, it's spread into two. To the trachea, we will divide it into bronchi, and it is divided into right, and also left bronchi, which supplies goes into the right and left lung. This is the another thing that you should know. This is the trachea. So as I mentioned previously, this is bronchi. Okay, this is the sagittal section. Sorry, not sagittal. It's a transverse section of a human body. You can see this at the hilar part. You can see this is the hilum, where the pulmonary artery is going on, going into the right and also left lungs, and then it's becoming a small capillaries that encase the alveoli. So again, this is just a normal anatomy. This is what histologically what you can see in the large airway. There will be cartilage, some glands here, bronchial glands, and the lining epithelium, which is pseudostratified ciliated columnar epithelium. And for the alveoli, you can see all of these. The empty whitish area here is actually the alveolar space. It doesn't look nicely as in the anatomy textbook or in a diagram or in illustrations, but this is the real alveoli looks like. It's a bit distorted shapes. It does not um, resemble a nice round shape like in the illustration. So this is the alveoli. So the empty here is the alveolar space where usually air will come here, and then there are small capillaries in the wall where the oxygen and also carbon dioxide um, exchange occur to facilitate in the ventilation and so perfusion. Next is the physiology. Um, there are two physiological or immunological aspect that you have to understand, because if there is a derange in this physiological process or immunological process, there will be some local defense. There will be some there will be loss of protections against bacteria or virus or anything that comes into the airway. So number one is the local defensive mechanisms, where it acts locally. Local means near the alveolar. So there is a bacteria coming in, so there will be some neutrophils here, and also macrophage that will eat all the bacterial, also fungal, also or viruses that enters our airway. It will eat all the thing and become attached to the mucosal lining of the large airway, in which they will produce a lot of mucus, which encase all these uh, white cells and also bacteria, and will be expelled out as a phlegm during coughing or sneezing. So again, this is just the same. This is act as if there is a repetitive kind of infections, so there will be uh, plasma cells or memory B cells which produce antibody that will bind initially with the bacteria also, or viruses or fungus, and then this will be act faster by the help of macrophages and also neutrophils. And again, it's the same with the act of coughing reflex. It will move all these things to the large airway, and then mucus will be secreted to encase everything here and remove um, later during coughing or sneezing. So again, this is the one of the important protective mechanism that we have in our body, which is the cough reflex. It is a defense mechanism. Uh, I, I, I'm, I'm, I'll just explaining a very simplified uh, process. But in detail, you need to go back to the physiological lecture to see the how does this reflex going on. But as a simplified manner, if there is some irritant in the airways, it will stimulate the receptor there, and it will send this receptor will send the signals through the afferent nerve or the vagus nerve to the medulla oblongata. So here will process the information and pass it back to the all of these muscles via afferent nerve or via the spinal, phrenic, and also vagus nerve. So all of this nerve is involved as a conduction of the information that has been processed, and it will supply, it will be stimulating all of these nerve, all of these muscles, which is the diaphragm, the intercostal muscle, larynx, and also abdominal muscle to initiate cough reflex. So this is the simplified version of the cough reflex, but in detail, we need to go to the physiology lecture to understand more. Okay, we go straight away to our topics, which is the lobar and also bronchopneumonia. So there are two types of pneumonia. Number one is lobar, and then number two is bronchopneumonia. So the pathogenesis, if there is a chronic disease or immunological deficiency or treatment with immunosuppressive agent or leukopenia, it will impact the local defense mechanism. As I mentioned before, if there is the local defense mechanism, which is by the help of macrophages and also neutrophils, so all of these local defense mechanism will be impaired. So our body has lost its protective or defense mechanism. So when all of this happen, so the bacteria will colonize in the lungs and also large airway. And apart from that, if there is factors interfere with the defense mechanism, for example, if there is a loss of suppression of the cough reflex, for example, in coma, anesthesia, neuromuscular disorder, or sometimes in a patient who had some injury to the mucociliary apparatus, in which patient who or a person who has smoked have is a usual cigarette smoker, or when there's some accident of inhalation of corrosive gases or some genetic defect which impact the ciliary process of the lining mucosa. So this will against will interfere with the defense mechanism. Apart from that, if there is accumulation of secretion, for example, in chronic bronchitis, in which there is a lot of mucus being secreted and unable to be excreted through cough reflexes. So this is a good medium for the bacteria to grow on in. And apart from that, if there is an interference with the phagocytic or bactericidal action of alveolar macrophages, for example, in alcohol, tobacco smoking, oxygen intoxication, all of these are the example that in which will interfere the ability of the macrophages to engulf the bacteria or the viruses. So this will cause interference of the defense mechanism. And the last one is if there is a pulmonary congestion and edema. So in this case, really you can find in patient with CCF or congestive cardiac failure or end-stage renal failure, in which they will sometime on and off persistently will have a pulmonary congestion and also edema. And if there is water or fluid, it is a good medium for the bacteria to grow in. So this will cause interference with defense mechanism and cause pneumonia to happen. So these are the example of types of bacteria that can cause pneumonia. For example, you can divide it into few parts, which is the community-acquired pneumonia and also community-acquired atypical pneumonia, hospital-acquired pneumonia, aspiration pneumonia, chronic pneumonia, and pneumonia in compromised hosts. All of these different subtype of groups of bacteria that causing pneumonia usually need a special causative or pathogenesis that can occur. But this one you can go have a look after this lecture in my lecture notes, and also sometimes you can find in the textbook. You can also have a look on it. Okay, next is for the gross feature for pneumonia. Okay, so you can, I've mentioned you already, there's a two type of pneumonia, which is the bronchopneumonia and also the lobar pneumonia. So let's go for the bronchopneumonia first. You can see this is a lung had been sectioned. So this actually had been cut into, had been dissected or being cut into two. So you can see this is the upper lobe and this is the lower lobe. And you can see there's some pale area in this part. Here are the pale area. Just highlight it for you. And don't worry, this one is the one, the one I highlighted with green is just a fissure. And this the pale area is the part where the pneumonia occurs. This is the pneumonia. This is also the pneumonia. So you can see that the pneumonia occur in patch. So it's patch. Patch means different spots. So this is one spot, this is another spot. Also, you can see this is a big one spot here, and this is another spot. So it occurs in spots. So that is why this is the typical features of a bronchopneumonia. So grossly, you can see like this. Next is the lobar pneumonia. So as the name implies, the lobar pneumonia, so it only involves the lower lobes of the lungs. So this again, a whole lung that had been sectioned. So you can see this is the upper lobe, and this is the lower lobes. So the upper lobe is the healthy one. So you can see it's a good color. It's a beefy, like a brownish kind of colors. But the lower lobe is the one who, in which had been suffering lobar pneumonia. So this is the lobar pneumonia. So if you compare with these two, you can see that the color is a bit different. The one that had been involved with lobar pneumonia is a bit yellowish or tan or going to whitish, sort of whitish kind of color. This is because there's a lot of infiltration of inflammatory cells within it. So this is what make the color turns into a bit yellowish or whitish in the color. So I will show you the histological afterwards, and will help you explaining on why does this lungs happens to be a bit whitish or tan or yellowish in color. So this again the close up. This is the involved lungs. Okay, next is the histopathological features of the lobar pneumonia. Broncho and so lobar pneumonia. So you compare, this one is the smaller one is the normal one, the normal alveolar spaces or normal section from the lungs, and this one is the broncho pneumonia sections. So if you compare within the alveolar space here, one I mark green in color. In the normal alveolar, there is nothing inside. This is because in a living person, these spaces is actually is filled with gases or air. So after we process it and make it into slide, it will turn there's nothing within it. But in bronchopneumonia, you can see that there's a lot of this is one alveolar. Sorry, I changed the color first. Okay, this is one alveolar spaces. This is another one alveolar spaces. So if you compare this one with this one, so there's something inside it. So actually, what is inside the alveolar spaces here is actually the neutrophils, other inflammatory cells, for example, lymphocytes, and sometimes you can see bacterial colonies and also macrophages and also some red blood cells. And you can also see here is one vessels, is another vessel. So these vessels are dilated and packed or filled with red blood cells. So these are how the congested vessels looks like. So you can see congestion there. You can see inflammatory cells within the alveolar spaces. So this is how a bronchopneumonia looks like. So this is another close-up. You can see there's a lot of multiple cells here. So I'll help you to orientate first. So this is one alveolar space. This is another smaller one. This is another one. There's another one alveolar spaces. This is another. This is also another alveolar spaces, and this is another alveolar spaces. So within the alveolar space here, you can see there's a lot of, but there's multiple cells. So there's these cells. The blue one is the alveolar or the macrophages, which help to engulf or to eat all the bacterials or viruses that enters the airway. And you can see this one, the smaller one, the, if you can appreciate, it's just like a small spikes or dots here, is actually the lymphocytes, and the other are the red blood cells and some neutrophils, which are difficult to demonstrate here because neutrophil you need to see the nuclei of the cells. So neutrophil, they have two or three lobes nuclei, so you can see. So basically, there's a lot of inflammatory cells that have been infiltrated within the alveolar space here. So this is how a bronchopneumonia looks like. Next is for the lobar pneumonia. So you can see there's differences between the broncho and also lobar pneumonia. So the lobar pneumonia has a few stages. So the first stage is the congestion stage, where you can see there's a vascular congestion. You can see the vessels are dilated like here. So there's the red dot there is the red blood cells within the vessels. These are another vessels that have been um, filled with the red blood cells. So all of these are the congested vessels or vascular congestions. And within the alveolar space, so I will help you to orientate. This is the one alveolar space. So you can look clearly, there's some lining there. So this is one alveolar space, this is another one, this is another one. So within the alveolar space, there's a proteinaceous fluid. Sometimes you can see neutrophils and also bacteria within it. So how do you demonstrate a proteinaceous fluid? Yeah, so instead of a whitish color like here, so the alveolar space is filled with something in which it's appear to be pinkish and sort of granulated kind of materials there. So this is what proteinaceous fluid looks under histology. Okay, next stage is the red hepatization stage. So why it is called red hepatization stage? It is because grossly during this stage, the lungs will be a bit firmer compared to firmer and looks and feels like a liver. So hepatization mean hepa mean liver. So it feels or the consistency of the lungs is a bit similar to the liver. So because of there's a lot of red blood cells, neutrophil, and so fibrin within the alveolar spaces. So this is one alveolar spaces. This is another one. This is another one, and there's a lot more. Okay, so just to give you some idea, there's other area spaces, and within these area spaces are these things: the red blood cells, neutrophils, and fibrins. And because of the presence of this thing, it binds together. The fibrin will make like a net and 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 trap the red blood cells and so neutrophils, and that is why it makes the liver a bit firmer and looks like the lungs look become a bit firmer and looks like a liver. So this is why we call it the red hepatization stage. And the red thing is also the color of the roughly the color of the lungs is appear to be a little bit reddish in color. So sorry because just outside my room there's someone um, vacuuming the floor, so there will be some noise. So if you cannot hear me well, you just shout out and I'll try to increase my voice. All right, next is the gray hepatization stage. Again, I will explain why it's called hepatization. And gray is because grossly the color of the lungs had transformed from reddish in color into a grayish, like the picture, the gross picture that I've showed you earlier. So this is how that is why it is called a gray hepatization stage. So again, just to help you okay, this is one alveolar spaces, this is another one, this is another one big alveolar spaces, this is another one, and this is empty, contain nothing. So within these alveolar spaces, you can see there's a lot of fibrinosuppurative exudate. So the name, as the name implies, if there is a fibrino, it is contain fibrin. Suppurative means it contains pus or neutrophil. So you can see there's a strand here, strand of sort of fiber or thing right here. So these are the fibrin that we can see under the histology or under the microscope. And a mixture of this thing is the neutrophils with some necrotic debris. So all of these are treated as pus or neutrophils. So that is why the name implies as fibrinosuppurative exudates within the alveolar spaces. And the last stage is the resolution stage. So if this patient is able to survive and after intense course of antibiotics, so the lungs will heal or going towards healing. So this is what we call resolution stage. So within the alveolar spaces, after all of the infection is settled, these immune cells will be triggered to become necrotic by itself or become apoptotic. So all what is left is just a necrotic debris within the alveolar spaces. And if in a longer time, you can see that there will be some healing with fibrotic scar, or sometimes you can see a fibrotic scar within the lungs. So, for example, in this one, so this is one fibrotic scar, this is another one, this is another one, this is another one. So this again, this patient will heal, of course, but the lung will be scarred or become fibrotic, and this patient will sometimes needs a prolonged therapy, and also will be having some difficulty in breathing and some respiratory problems later because of the healing process. Next, the complication, and it's a clinical correlation for the pneumonia. So complication, of course, after if the pneumonia is not settled, become lung abscess or sometimes become sepsis, and patient will die due to sepsis. And for the clinical correlation, just like any other infections, there will be high grade fever. Because of the lung, patient become present with shortness of breath and also sometimes chest pain if there is involved the pleura, and also productive cough or uh, producing muco and also purulent kind of a sputum. Next is the lung abscess. Okay, so pathogenicity, how does it occur? Because there's or the definition first. The definition of the lung abscess is a local separative process within the lung characterized by necrosis of lung tissue. So there's a local separative process like pus collection within the lung. Okay, so it's characterized by necrotic of lung tissue and there's a lot of inflammatory cell within it. So the usual organism can read afterward, but the most common is Streptococcus, Staphylococcus aureus, gram-negative organism, Fusobacterium, and also Peptococcus species. But actually, all of these organism is based on the causes for this abscess. For example, if there's Staphylococcus aureus infection pneumonia previously, so this Staphylococcus aureus usually will cause the same is the same organism that caused the lung abscess. Okay, for the mechanism, if it starts with the aspiration of infective materials, for example, sputum, or sometimes aspiration pneumonia, so it can cause this. So what stimulate this aspiration of infective materials? For example, number one is acute alcoholism, sinusitis, coma, gingigo, dental sepsis, anesthesia, and also depressed cough reflex. So all of these things is what cause aspiration of the infective materials. Next is the antecedent primary lung infection. As I mentioned, if there is a bronchopneumonia or lobar pneumonia, it is predisposed this patient to occur to develop a lung abscess afterwards. Next is septic embolism. This, for example, if there is some infection elsewhere, for example, in infective endocarditis, in which there is some infective emboli, infective embolism at the heart valve, and this septic emboli can dislodge and uh, being carried away and land or being how you say end up in the lungs. So when this happens, so this septic emboli can cause lung abscess locally. Next is neoplasia, in which there's a bronchopulmonary segment obstruction due to this cancer or neoplasia or malignancy of the large airway. So the distal airway, usually there will be lung abscess. It will start with pneumonia first and then end up with lung abscess. And other miscellaneous condition, for example, direct trauma, for example, in gunshot or stab wounds, in which the tip of the dagger or knife or the bullet itself has some amount of bacteria within it. So when it penetrates into the lungs, it can cause lung abscess in this patient, or can be spread from a neighboring organ. For example, esophagus, is there is esophageal abscess, it can spread to the lung and cause pneumonia there. And other hematogenous seeding, for example, as I mentioned already previously, the septic emboli. So this is how it looks like. Usually grossly, this is another, again, a lung that had been sectioned. So you can see this hole within it. So layman we call hole, but in medical term we call it cavitations. So there is a cavitation here. So the size is sometimes it's very small, and sometimes it can go up to 5 to 6 cm or even more. It depends on the severity of the infections. And it can occur anywhere in the lungs. And the aspiration, if it is caused by aspiration, usually it's more common in the right side instead of the left side. So because the right side, the main bronchus is a bit vertically, so the food is easier to, or aspirated material is easier to enter that airway. And next is the air containing cavity. This is what it's called, cavity. And sometimes you can see there's a connection with the large airway. Okay, histopathologically, you can see there's the content of this cavitation is just actually a separative debris. And this separative debris also is a mixture of is a caused by destruction of the lung parenchyma, and also there will be some central area of cavitation. So this just to help you to orientate. So remember previously, so the alveolar space. So here is one alveolar space, here is one alveolar space. So you can see there's a lot of alveolar space here and also here. But at the center here, there are no alveolar spaces left because of the suppurative or the excesses that have been going on here. So you cannot see any more alveolar spaces, but you can see it's just necrotic debris with a lot of neutrophils within it. So this is how lung abscess look like if you take it and have a look under the microscope, or this is the histopathological features of it. The complication, majority resolve with scar formation. So sometimes after healing, there will be some respiratory problems for this patient. Usually need some bronchodilators or further follow up for his or her lungs or respiratory problems. Next is the extension of infection. Sometimes it can extend into the pleural cavity and cause empyema. It can cause hemorrhages or septic emboli to the brain, causing brain abscesses or sometimes meningitis. And sometimes during healing process, there will be a lot of amyloidosis, or amyloidosis is actually the proteinaceous material that had been secreted during inflammation, and after it had been healed, there will be a lot of this left and cannot be digested by our body and left with amyloidosis. And clinical presentation as similar with the pneumonia previously. Apart from that, there will be a lot. This is the most common, another common findings. This is chest pain, because this lung abscess is usually a chronic chronic process. There will be some loss of weight, clubbing, and you need to seek radiological investigation to confirm it. And sometimes there will be chances of carcinoma developing in the large airway in 10 to 15% of cases. And the last one before we go into special issue is the empyema. Empyema, okay, just to refresh back regarding the anatomy. So there's a lung. So between the lung and also the chest wall, thoracic cage, and also the muscles, there is a space there. So this space is what we call pleural space. So this pleural space is where the empyema will be collecting in. Next, okay. Really, the definition is passed within the pleural cavity or pleural space. Okay, the mechanism usually it start with pneumonia and then it can become empyema and pneumonia, then it spread to the pleural cavity and causing empyema. Or sometimes you can see empyema in the chest after chest surgery, or sometimes traumatic. So direct traumatic, as I mentioned previously, stab wound or gunshot wound where the the stabbing object is a bit that contain a lot of bacteria within it, so it can cause pneumonia within empyema for this patient. So usually the most common bacteria is the streptococcus and also staphylococcus aureus, and also there's other organism. It depends on the type of pathogenesis. So morphologically, usually we diagnose empyema if we do the cytological assessment. So cytology means we poke the ribs at the fourth and fifth intercostal space, and we drain out the pus from these patients. So what you can see under cytological examination is there is abundant neutrophils. So there's a lot of neutrophils, like in this picture. You can see there's a lot of neutrophils. So where are the neutrophils? So let's see. All right. So this is one neutrophil. You can see. Sorry. So this is one neutrophil. You can see there's a T3 dot within it. So that is a neutrophil nuclei. So neutrophil usually have trilobes or bilobes nuclei. So this is another neutrophil. This is another neutrophil. You don't have to count, but you have to know that there's a lot of neutrophil within it, within the fluid that has been sent to us, the histopathology. So, but if you perform an X-ray or MRI, you can see the air fluid levels. So, what is air fluid levels? It is this thing. Okay, the air is above here, the air, and the fluid is underneath here. And these levels is what we call the air fluid levels, the air and fluid level. So you can see this thing if you do a radiograph or radiological investigation, which is the X-ray, or if you do MRI or CT scan, you also can see the air fluid level, which is in this case is here. Sorry, it's a bit at the side here. So above here is air, black in color. Fluid is down here, which is white in color. So in between it is the air fluid level, right? So that's what you find in clinically. So this is how empyema looks like. So usually doctor or the managing clinician will insert a chest tube. So this is chest tube, right? So they insert this chest tube and drain it out. So when you drain out, so the pus will coming out. So this is the pus, how the pus looks like. Sometimes it is a bit yellowish and brownish, like teh tarik kind of a color. So that is how it looks like, the pus within the empyema. All right, the complication usually if is left untreated or if it's treated as well, the patient can present with bronchopleural fistula, where there's a channels connecting with the pleura from the inside of the chest wall, from pleura and into the outside to the skin. So there'll be some fistula there. Or patient can present it with recurrent empyema. As you know, it's very difficult to treat empyema because there is a very close space, and sometimes even if we give antibiotics to this patient, sometimes it won't kill 100% of the bacteria. So the patient will come with recurrent empyema and need further course of antibiotics to help him or her become healthy again. And if by times there will be some pleural thickening, and the patient will be presented with restrictive lung disease and may require decortications. Decortication means the cardiothoracic surgeon will strip off the not strip off it the cardiothoracic surgeon will fuse together the visceral and also the parietal the parietal pleura. So meaning there's two layers of pleura, the one which near the visceral with the organs, and another one which attached to the thoracic cage. So they will fuse these together to make sure that there won't be any restrictive lung diseases. Next, the clinical correlation is similar with the previous one: cough, fever, chest pain, and also shortness. All right. During these pandemics, sometimes we need to understand how does COVID-19 pneumonia can affect a patient or a person. This is a special issue which I include for this pandemic's time. Okay, so this is what from the extensive reported cases in the journals and the medical journal. There are a lot of findings that can be associated with the COVID-19 infections. Usually, it will cause bilateral involvement. That's the most important thing. And when they assess the lung of disease or due to COVID-19, there will be a lot of pulmonary thromboembolism and also mucinous and hemorrhagic exudates. And apart from that, there will be some spotty involvement of lungs. You can see there's edematous lung, which is lung appear to be a bit heavy. There will be some congestion, the punctate hemorrhagic necrosis. And all of this is caused by this CD4 and CD8 T cell cytokine storm. All of these are caused by the T cells actions towards the infections. Because T cells trying to save us from this pneumonia, from try to attack the COVID-19, but in the process, it causes cytokine storms and causing all of these conditions. And usually, patient the condition becomes severe, and usually patient succumb to the process. So this is how it looks like. So you can see the lung is a bit boggy, a bit heavier compared to the, not heavier, appear to be enlarged or dilated or become congested compared to the previous, compared to the normal lungs. So this is how it looks like. You can see the lung appear to be boggy and enlarged. So this is because of there's a congestion there. So this cut section, you can see there's a hemorrhagic congested lung tissue here. And there will be also some pulmonary artery thrombosis with lung infarction. So this is why COVID-19 causes death. Most of the death caused by COVID-19 is due to lung infarction. There's a thromboembolism within the large airway and causing the patient to die afterwards. So, so this is important to educate the layman or educates the community to get vaccinated, because some, if you familiar with the current topics, they are saying that due to AstraZeneca vaccination, there's a lot of there are chances to develop blood clots after taking AstraZeneca vaccines. So, but if you compare cases of blood clots after the vaccination of AstraZeneca and blood clots in a patient who had COVID-19, the later, or the patient who had COVID-19, have been infected by COVID-19, has a higher chances to develop blood clots in compared to patient or person who taking AstraZeneca, because initially in 1 million person who receive AstraZeneca doses of vaccines, only 4 to 6 people who get who had reported to have a blood clots incident. So this is very low in compared to if you contracted COVID-19 viruses or infection. So this is important to educate, because there's a lot of anti-vax people or person who are against the vaccination will be sort of telling these false lies to you. So this is how you do. These are the point how you overcome this false misinformation that have been spread by these kind of peoples. So next is the histopathological features. So there will be a lot of diffuse alveolar damages that can be seen histologically. There will be some cellular and interstitial damages. So you can see in the chest X-ray, there's a lot of pneumonic changes. So there's a lot of whitish spot here and there, and involved by both or bilateral of the lungs. So this is what causing the patient had difficulty in breathing after the infection of COVID-19. So histologically, you can see there's some pneumonic changes here in this area. There's a lot of alveolar spaces that have been filled with red blood cells and also neutrophils. And apart from that, so you can see also there's a diffuse alveolar damage where the alveolar spaces become damaged and destroyed by the act of the CD4 cells. So that is why the patient died due to COVID-19. This is because there is diffuse alveolar damage. Because once the alveolar spaces is damaged, there's no way you can replace it, or you can I would say that you can pump in or you can give oxygen to the patient because the alveolar has already been damaged. So that's the severity of the COVID-19. So this is another images that can show diffuse alveolar damage. This is close up of the alveolar spaces. This is one alveolar spaces, but you can see this area, this pinkish material. This is actually all of the alveolar walls that have become necrotic or been damaged due to process of CD4 cells trying to overcome the COVID-19 viruses. So this again another one. So you can see this a pinkish material here. So these are all the necrotic damaged alveolar lining. So for the histopathological features, apart from that, will be some exudative phase, proliferative phase, and extrafibrotic phase. This is just similar with lobar pneumonia phases or stages. Apart from that, you can see there's a multinucleated giant cells, like in this picture. This is a multinucleated giant cell. As the name implies, it's a large cells which has or contains a lot of nucleus within it. And apart from that, there's an interstitial and also alveolar inflammations and also necrotizing alveolitis. And for the bronchi, there will become chronic inflammations, thickening of edematous mucosa, necrotizing bronchiolitis, alveolar epithelial change. For example, there will be atrophy, proliferation, and also squamous metaplasia in less severe cases. So in this picture, is actually I just wanted to show you that this is one large arterioles within the lungs, within the lung parenchyma. So you can see this is the arteriolar walls, which consists of smooth muscles. So smooth muscle appear to be pinkish in color. But the most important thing is to see what inside it. So inside of these blood arterioles is a blood clot. So this is what COVID-19 due to vessels in the lungs. So it stimulates blood clots within the lungs. So that is why another point why there's a lot of congestion and why there's a lot of patient died due to COVID-19. All right, this is another point that which I mentioned previously. There will be a lot of fibrin thrombi, fibrinoid necrosis, wall thickening, so liminal stenosis. This is another, again, how blood clot looks like, and this one is what fibrinoid necrosis looks like. Fibrinoid necrosis occur to the alveolar wall. So you can see there's a necrosis of the wall here. Some of the smooth muscle is still present here. And this is the fibrinoid necrosis of the wall. Next is the most important, not the most important thing, just to support that this infection is caused by COVID-19, there will be some cytopathic effects. So usually that in any viruses infections, there will be some cytopathic effect. Cytopathic means what does the virus do to the cells that transform the way it looks. So in COVID-19 infections, if you see or you look closely to the pneumocytes in the lungs, you can see there will be some cytomegaly, nuclear enlargement, and prominent eosinophilic nucleoli, and with eccentric intracytoplasmic inclusion. So you can see this is one pneumocytes. What you can see is pneumocyte. This pneumocyte is already enlarged. So this is a bit difficult to see in this picture because you need to compare with the surrounding tissue, but bear with me. The nuclei is a bit enlarged. So this is the nuclei of the cells. A bit enlarged with the prominent eosinophilic nucleoli. So this is another one. This is the nuclei. And you can see that inside there is the black dots. There is what we call nucleoli, or in this case, in this picture, so this is the nuclei, and at the center there is the nucleoli that have become very prominent and very eosinophilic. Eosinophilic means a bit reddish or orangish color of the materials. And also eccentric intracytoplasmic inclusion, which is here. Eccentric means at one side, so it is at one side. Okay, by that I end my lecture. Thank you very much for attending my lectures. I won't have much time to answer your questions, but I'm happy to answer it if you post it or email it to me. I will try to answer it as much as possible. And I hope you will have a nice day and a nice lecture ahead. So if there's anything, all right. So by that, I end my lecture. So if anything, you can ask me, you can email me, or you can, you can find me through my other modalities that are available in the e-learning space. So thank you. Goodbye and have a nice day.
Thank you, Prof.
Thank you, Doctor.
Thank you, Doctor.
Thank you.
Thank you, Doctor.
Thank you, Doctor.